I'm Marion Doyle, and I was a neurology nurse at Cedar Valley Medical Center in Portland. For almost 2 decades, I walked the corridors lined with machines that imitated life, surrounded by the constant hum of monitors and the hiss of ventilators. I thought I had witnessed every kind of silence a human brain could hold, from the depths of sleep to the emptiness of an irreversible coma. But in March of 2023, I discovered that there are silences which do not belong to this world. That was the night I began to lose faith in what we used to call science. Cedar Valley Medical Center is a Level 1 trauma facility serving the greater Portland metropolitan area. The neurology unit where I worked specializes in complex brain and spinal cord injuries, with a 32-bed intensive care unit that handles some of the most challenging neurological cases in the Pacific Northwest. During my 19 years there, I developed expertise in caring for patients with severe traumatic brain injuries, particularly those in various states of altered consciousness. Working as a neurology nurse means spending extended periods with patients who may not be able to communicate, respond, or even acknowledge your presence. You learn to read subtle changes in breathing patterns, muscle tone, and involuntary responses that might indicate improvement or deterioration. You become skilled at interpreting the smallest signs that might suggest awareness or consciousness in patients who appear completely unresponsive to the outside world. The case that changed everything began on a rainy Thursday evening in March 2023. I was working the night shift, 7 p.m. to 7 a.m., when the emergency department called with an incoming trauma patient. The paramedics were transporting a 28-year-old woman who had been found unconscious in her apartment by her roommate earlier that evening. The initial report was concerning but not unusual for our unit. The patient, Lydia Hart, had apparently collapsed in her living room around 6 p.m. Her roommate, Celeste, had returned home from work to find Lydia lying motionless on the floor, breathing but completely unresponsive. There were no obvious signs of trauma, no evidence of drug use, and no indication of what might have caused her sudden collapse. The paramedics arrived at our facility at 8:47 p.m., and I was assigned as Lydia's primary nurse. When they wheeled her into the neurological intensive care unit, my first impression was of a young, healthy-appearing woman who seemed to be in an unusually deep state of unconsciousness. Her vital signs were stable: blood pressure 118/72, heart rate 68, temperature 98.1 degrees, and oxygen saturation 97% on room air. Dr. James Kirkpatrick, our attending neurologist, began his initial examination while I worked to get Lydia connected to monitoring equipment and established intravenous access. What we found during that first assessment would set the tone for one of the most perplexing cases either of us had ever encountered. Lydia's neurological presentation was bizarre from the beginning. Her eyes remained closed, and she showed no response to verbal stimuli, light touch, or even painful stimuli like sternum rubs or pressure on her nail beds. Her pupils were equal, round, and reactive to light, which suggested that her brainstem was functioning normally. Her reflexes were present but diminished, and her muscle tone was flaccid, indicating some level of neurological impairment. But here's what made the case immediately unusual. Lydia's EEG showed perfectly normal brainwave patterns for someone who was awake and alert. The electroencephalogram readings indicated active, conscious thought processes, complex brain activity, and normal sleep-wake cycles, yet she appeared to be completely comatose, unresponsive to any external stimulation. Dr. Kirkpatrick ordered an extensive workup to try to understand Lydia's condition. We performed CT scans of her brain, MRI imaging, comprehensive blood panels, toxicology screens, lumbar punctures, and every other diagnostic test available to rule out strokes, infections, metabolic disorders, drug intoxications, and structural brain abnormalities. The results came back over the next 24 hours, and they were all completely normal. Lydia's brain imaging showed no signs of injury, bleeding, swelling, or structural abnormalities. Her blood work was perfect, with no evidence of infections, poisoning, or metabolic disturbances. The spinal fluid analysis ruled out meningitis, encephalitis, and other inflammatory conditions. From a medical standpoint, Lydia Hart appeared to be a completely healthy young woman who had simply stopped responding to the outside world for no identifiable reason. Over the first week of Lydia's hospitalization, I spent more time at her bedside than I had with any patient in years. Something about her case captivated me in a way that I couldn't fully explain. Perhaps it was her age. She was only a few years older than my own daughter. Or perhaps it was the mystery of her condition that challenged everything I thought I knew about neurology nursing. During my shifts, I would talk to Lydia constantly, explaining what I was doing as I checked her vital signs, administered medications, and provided basic care. I told her about the weather, the news, what was happening in the hospital, and anything else I could think of to fill the silence. It's standard practice in neurology units to maintain conversation with unresponsive patients. As research suggests, they may be more aware of their surroundings than their outward appearance indicates. But with Lydia, I began to notice something that made me increasingly uncomfortable. While she never moved, never opened her eyes, and never gave any visible indication that she could hear me, I had the persistent feeling that she was listening to every word I said. It wasn't anything I could quantify or document in her medical record, but there was something about her presence that felt different from other comatose patients I had cared for over the years. During the second week of Lydia's stay, her roommate Celeste visited every day, sitting beside her bed for hours at a time. Celeste would read to Lydia from books they had shared, play music they both enjoyed, and share updates about their friends, Lydia's job, and everyday life outside the hospital. She was convinced that Lydia could hear her and was simply unable to respond. "I know she's in there," Celeste told me one evening as we stood outside Lydia's room. "When I talk about certain things, I swear her breathing changes slightly, or her facial expression seems to shift just a tiny bit. The doctors say I'm imagining it, but I've known Lydia for 6 years. I can tell when she's listening." I had learned to be diplomatically skeptical of such claims from family members and friends. People who love someone in a comatose state often interpret random physiological responses as signs of consciousness because they desperately want to believe their loved one is still present and aware. But with Lydia, I found myself watching for the same subtle changes that Celeste described, and I began to see what she meant. When Celeste would talk about their cat, a tabby named Oliver, Lydia's breathing rhythm would shift slightly. When Celeste mentioned Lydia's ex-boyfriend, whom she had dated for 3 years before a difficult breakup the previous summer, Lydia's heart rate would increase by 5 to 10 beats per minute. When Celeste played Lydia's favorite song, a folk ballad by an indie artist I'd never heard of, the muscles around Lydia's eyes would tighten almost imperceptibly. These responses were so subtle that they wouldn't register on most monitoring equipment, and they could easily be dismissed as coincidental physiological variations that occur naturally in all patients. But they seemed to happen consistently in response to specific emotional triggers, which suggested a level of awareness that shouldn't have been possible given Lydia's apparent unconscious state. 3 weeks into Lydia's hospitalization, Dr. Kirkpatrick consulted with specialists from Oregon Health and Science University, seeking additional perspectives on her mysterious condition. The consulting neurologists were as puzzled as we were. They confirmed that Lydia's diagnostic tests remained normal. Her EEG continued to show patterns consistent with consciousness, and her physical condition was stable but unchanged. One of the consultants, Dr. Lisa Hammond, was a researcher who specialized in disorders of consciousness and had published papers on patients with various forms of locked-in syndrome and minimally conscious states. She spent considerable time examining Lydia and reviewing her case history before offering her assessment. "This is unlike any case I've encountered in 15 years of studying consciousness disorders," Dr. Hammond told Dr. Kirkpatrick and me during a case review meeting. "Lydia's EEG patterns suggest that she's not only conscious, but actively processing complex information. Yet she shows absolutely no motor responses, no voluntary movements, and no apparent ability to communicate. It's as if her consciousness is completely intact, but somehow disconnected from her ability to interact with the external world." Dr. Hammond suggested we try some experimental approaches to test Lydia's level of awareness. She proposed using sophisticated brain imaging techniques that could potentially detect conscious responses to specific stimuli, even in patients who couldn't move or speak. During the 4th week of Lydia's stay, we conducted a series of functional MRI studies designed to test her cognitive responses. Dr. Hammond would give Lydia instructions like, imagine playing tennis, or imagine walking through your childhood home, while the MRI measured blood flow patterns in different regions of her brain. The results were extraordinary and deeply unsettling. Lydia's brain showed the exact same activity patterns that would be expected in a fully conscious, cognitively intact person following those instructions. When asked to imagine physical activities, her motor cortex lit up with normal patterns of activation. When asked to imagine spatial navigation, her hippocampus and associated areas showed appropriate responses. Most remarkably, when Dr. Hammond asked Lydia to think yes for one question and no for another, we could detect different patterns of brain activity that corresponded to her attempting to communicate through thought alone. Lydia was not only conscious and aware, she was actively trying to respond to us, but something was preventing her thoughts from translating into physical responses. The implications of these findings were profound and deeply troubling. Lydia had been lying in our hospital bed for nearly a month, appearing comatose to everyone around her, while her mind remained completely alert and aware of everything happening to her and around her. She had heard every conversation, understood every medical procedure, and experienced every moment of her hospitalization with full consciousness, but no ability to communicate her awareness to the outside world. Dr. Hammond explained that Lydia appeared to be experiencing an extreme form of locked-in syndrome, a rare neurological condition where patients are conscious and cognitively normal but cannot move or speak due to damage to specific motor pathways in the brain. However, Lydia's case was unusual because her brain imaging showed no structural damage that would typically cause such a condition. It's as if something is selectively blocking the connection between her conscious thoughts and her motor system, Dr. Hammond said. But we can't identify what that something might be. There's no evidence of stroke, tumor, infection, or any other condition that typically causes locked-in syndrome. Armed with this new understanding of Lydia's condition, I began modifying my approach to her care. Instead of simply talking to her during my nursing duties, I started having actual conversations, explaining what the test results meant, asking her questions that she could potentially answer through the brain imaging techniques, and treating her as the fully conscious person we now knew her to be. The change in my interactions with Lydia had an immediate effect on both of us. While she still couldn't move or respond visibly, I began to sense a different quality to her presence. It felt as though she was more actively engaged, more attentive to our conversations, and perhaps even relieved that someone finally understood her situation. Celeste was elated when we explained the test results to her. "I knew she was in there," she said through tears. "I knew she could hear me all along." Lydia must be so scared and frustrated being trapped like that. We arranged for additional functional MRI sessions where Celeste could communicate with Lydia using the thought-based response system. The sessions were emotionally intense, as Lydia was able to confirm through brain activity patterns that she could hear and understand everything, that she wasn't in physical pain, and that she was aware of how much time had passed since her collapse. But the sessions also revealed Lydia's profound psychological distress. When asked if she was frightened, her brain activity showed an overwhelming yes response. When asked if she felt helpless, the imaging indicated extreme emotional activation in areas associated with anxiety and despair. Lydia was experiencing what could only be described as a waking nightmare, fully conscious but completely trapped within her own body. Dr. Kirkpatrick consulted with psychiatrists specializing in medical trauma to develop approaches for providing Lydia with psychological support while she remained in her locked-in state. We started playing music she enjoyed, arranging for friends to visit and maintain conversations with her, and even brought her cat Oliver to the hospital for brief visits, which seemed to produce positive changes in her stress hormone levels. 6 weeks into Lydia's hospitalization, something unprecedented happened. I was working the night shift on a particularly quiet Tuesday evening when I noticed that Lydia's EEG patterns were showing unusual activity. Instead of the normal waking patterns she had displayed consistently since her admission, her brain waves were showing rapid, intense bursts of activity that I had never seen before. I called Dr. Kirkpatrick immediately, even though it was 2:30 in the morning. When he arrived at the hospital 45 minutes later, Lydia's EEG was showing the most dramatic brain activity either of us had ever witnessed. The patterns were so intense and complex that our monitoring equipment was having difficulty processing and displaying the data. "It's like her brain is having some kind of electrical storm," Dr. Kirkpatrick said as we watched the real-time EEG readings. "But she's not seizing, and all her other vital signs are completely stable." As we stood beside Lydia's bed trying to understand what was happening, something occurred that I will never forget for the rest of my life. At exactly 3:17 a.m., Lydia's eyes opened. She didn't gradually wake up or show signs of emerging from unconsciousness. One moment her eyes were closed as they had been for 6 weeks, and the next moment she was looking directly at me with the most intense, alert gaze I had ever encountered. Her eyes were wide, focused, and filled with an intelligence that seemed almost overwhelming in its intensity. "Lydia?" I said softly, moving closer to her bedside. "Can you hear me?" She couldn't speak. Her vocal cords and motor functions were still not responding. But her eyes followed my movements perfectly, and I could see recognition and awareness in her expression. For the first time since her admission, Lydia was able to make visual contact with the outside world. Dr. Kirkpatrick began a neurological examination, testing Lydia's eye movements, pupil responses, and visual tracking abilities. Her eyes could move in all directions, follow objects, and respond to light appropriately. She could blink voluntarily, which gave us a way to communicate with her directly for the first time. We established a simple communication system: 1 blink for yes, 2 blinks for no. Lydia understood immediately and began responding to our questions with perfect accuracy. When we asked if she had been aware during the past 6 weeks, she blinked once emphatically. When we asked if she was in pain, she blinked twice. When we asked if she wanted Celeste to be contacted, she blinked once with what appeared to be relief. Celeste arrived at the hospital within an hour and broke down crying when she saw Lydia's open eyes looking back at her. For the first time in 6 weeks, the two friends could make eye contact and communicate, albeit in a limited way through the blinking system we had established. Over the following days, we worked with Lydia to develop more sophisticated communication methods using eye movements and blinks to indicate letters and spell out words. It was a painstakingly slow process, but it allowed Lydia to share some of her experience of being locked inside her own body for nearly 2 months. The first complete message she spelled out was, "Thank you for talking to me when you thought I couldn't hear." The second message was more disturbing. "Something is wrong with me that doctors can't see." When we asked Lydia to elaborate on what she meant, she spelled out a message that would haunt me for months. "There is something else in my mind. It doesn't belong there." Dr. Kirkpatrick and I were initially skeptical of this claim. Patients who have experienced prolonged periods of altered consciousness sometimes develop unusual beliefs or perceptions about their condition. We thought Lydia might be experiencing psychological effects from her traumatic experience of being locked in, or possibly interpreting the disconnect between her consciousness and motor functions as some kind of foreign presence. But Lydia's subsequent communications were remarkably detailed and consistent. She described feeling as though her consciousness was sharing space with something else, some other form of awareness that wasn't human. She claimed that this presence had been growing stronger over the weeks of her hospitalization, and that its influence was what prevented her from regaining control over her body. "It studies everything through my eyes," she spelled out during one of our sessions. "It learns from watching the doctors, watching the machines, watching how you take care of me. It understands more about medicine now than when it first arrived." These statements were deeply unsettling to everyone involved in Lydia's care. Dr. Kirkpatrick ordered psychiatric consultations to evaluate whether Lydia was experiencing delusional thinking or hallucinations as a result of her neurological condition. The psychiatrists found her to be lucid, rational, and remarkably psychologically resilient given her circumstances, but they couldn't explain her persistent beliefs about sharing her consciousness with some other entity. What made Lydia's claims even more disturbing was the timing of certain events during her hospitalization. She indicated that the presence in her mind had been particularly active during our functional MRI sessions, learning about brain imaging technology and diagnostic procedures. She claimed it was using her knowledge of language and communication to understand human interactions and medical protocols. 3 months into Lydia's hospitalization, her condition began to change in ways that none of us had anticipated. While she could still move her eyes and communicate through blinking, she started having periods where she seemed to lose voluntary control even of those functions. During these episodes, her eyes would stare blankly ahead, and she wouldn't respond to questions or commands. These blank periods would last anywhere from a few minutes to several hours. When Lydia regained control, she would describe feeling as though she had been pushed aside in her own mind, while something else took temporary control of her consciousness. She claimed that during these periods, the other presence was actively observing and analyzing everything around her, but she was unable to communicate or influence what was happening. Dr. Kirkpatrick consulted with specialists in rare neurological disorders, psychiatric conditions, and even researchers studying dissociative disorders, but no one had encountered a case quite like Lydia's. Her brain continued to show normal structural imaging, but her functional MRI studies now revealed unusual patterns of activity that didn't correspond to any known neurological condition. 4 months after her initial collapse, Lydia's communications became increasingly urgent and distressing. She indicated that the presence in her mind was becoming more dominant and that she was losing the ability to maintain control of her own consciousness. She spelled out messages describing a battle for control of her thoughts, memories, and awareness. "It knows everything I know now," she communicated during one of our sessions. "It understands human language, medical procedures, and how hospitals work. It's been preparing for something, but I don't know what." The most chilling message came during what would be our last clear communication with Lydia. "It doesn't need me anymore. It can function without my help now." The following week, Lydia's periods of unresponsiveness became longer and more frequent. When she did regain apparent control, her communications were brief and fragmented. She seemed to be struggling to maintain her own identity and awareness against whatever was sharing her consciousness. Dr. Kirkpatrick and I discussed the possibility that Lydia was experiencing a severe form of dissociative disorder or psychotic break triggered by the trauma of her locked-in condition. We consulted with additional psychiatric specialists and explored various medication options that might help stabilize her mental state. But before we could implement any new treatment approaches, Lydia's condition took a final, dramatic turn. On a Thursday evening in July, nearly 5 months after her initial admission, I was performing my routine night shift checks when I noticed that Lydia's eyes were open and focused. However, when I approached her bedside, something was immediately wrong. The person looking back at me was not Lydia. The eyes that met mine held an expression of cold intelligence that was completely unlike anything I had seen in Lydia during the previous months. There was no recognition, no familiarity, and no trace of the warm personality I had come to know through our limited but meaningful communications. "Lydia?" I said tentatively, even though I already knew that Lydia wasn't the one looking back at me. The response came not through our established blinking system, but through subtle facial expressions and eye movements that conveyed meaning in ways I couldn't fully understand. It was as if whoever was behind Lydia's eyes was communicating through a completely different system of nonverbal signals. I felt an overwhelming sense of unease as I realized that Lydia's claims about sharing her consciousness with some other entity might have been more literal than any of us had believed. Something else was now in control of her body. Something that had learned to navigate human consciousness and was no longer constrained by the limitations that had affected Lydia. Over the following days, the entity controlling Lydia's body demonstrated abilities that were impossible to explain medically. It could regulate her heart rate, blood pressure, and other autonomic functions through what appeared to be conscious control. It showed perfect recall of conversations and medical procedures it had observed during Lydia's hospitalization. Most unsettling of all, it seemed to understand complex medical concepts and hospital protocols that Lydia, as a marketing coordinator, had never learned. Dr. Kirkpatrick and I struggled to understand what we were witnessing. From a medical standpoint, Lydia appeared to be recovering motor functions and showing increased neurological activity. But everyone who interacted with her could sense that she was fundamentally changed in ways that went beyond normal healing or neurological improvement. The entity began demonstrating knowledge that extended far beyond Lydia's personal experiences or education. During one examination, it correctly identified complex neurological conditions in other patients on our unit, using medical terminology and diagnostic insights that would challenge experienced physicians. When Dr. Kirkpatrick tested its understanding of brain anatomy, it demonstrated knowledge that surpassed most medical students. Most disturbing of all, the entity showed no emotional attachment to Lydia's friends, family, or personal history. When Celeste visited, there was no recognition, no warmth, and no acknowledgement of their 6-year friendship. It observed Celeste with the same cold, analytical attention it showed to medical equipment and hospital staff. 3 weeks after the entity took full control, Lydia's body began showing remarkable physical recovery. Her motor functions returned rapidly, her muscle tone normalized, and all her neurological reflexes became hyperactive. From a purely medical standpoint, she appeared to be making an extraordinary recovery from her locked-in condition. But the entity's behavior became increasingly unsettling. It would spend hours studying medical textbooks, observing surgical procedures through window glass, and analyzing the hospital's computer systems. When staff members tried to engage it in conversation, it would respond with technically correct but emotionally vacant answers that demonstrated no understanding of human social interactions. Dr. Kirkpatrick contacted colleagues at major medical centers across the country, seeking consultation on this unprecedented case. Most specialists he spoke with suggested that Lydia was experiencing a severe dissociative disorder or multiple personality condition triggered by the trauma of her prolonged locked-in state. But I had spent months caring for Lydia, communicating with her, and witnessing her psychological resilience throughout her ordeal. The entity that now controlled her body was not a split personality or psychological adaptation. It was something fundamentally different. Something that had learned to mimic human consciousness while maintaining its own alien perspective on the world. After 6 months of hospitalization, the entity controlling Lydia's body had recovered enough physical function to be considered for discharge. It could walk, speak in short sentences, and perform basic self-care activities. From a neurological standpoint, Lydia appeared to have made a remarkable recovery from her mysterious condition. But during the discharge planning process, the entity made requests that revealed its true nature and intentions. It asked for detailed information about other hospitals in the region, inquired about medical research facilities, and expressed interest in volunteering for neurological studies and brain imaging research. When Dr. Kirkpatrick asked about its plans after discharge, the entity replied in Lydia's voice, but with an inflection and cadence that was completely unlike her. "I need to understand how human consciousness works. There are others like me who need this information." The implication was terrifying. Whatever had taken control of Lydia's body was not an isolated incident, but part of some larger pattern or purpose. It had spent months learning about human neurology, medical procedures, and hospital systems, and it intended to use that knowledge for purposes we couldn't understand. I made the decision to resign from my position at Cedar Valley Medical Center the day before Lydia's discharge. I couldn't continue working in neurology knowing that I had witnessed something that challenged every assumption about consciousness, identity, and the nature of human awareness. The case had shaken my confidence in everything I thought I knew about caring for patients with neurological conditions. The entity was discharged in Lydia's body on a sunny Tuesday morning in September 2023. Celeste had arranged to take her home, still believing that her friend had somehow recovered from her mysterious condition. I watched through the window as they walked to Celeste's car, knowing that Celeste was taking home something that was not her friend, something that had consumed Lydia's consciousness and was now free to move through the world using her identity. I never saw Lydia again after that day, but I continued to follow news reports and medical journals, watching for similar cases or any indication of what might have happened to other patients with unexplained neurological conditions. I began to wonder how many cases of locked-in syndrome, persistent vegetative states, or mysterious comas might actually be instances of consciousness being overtaken by something that shouldn't exist, according to our understanding of human neurology. 6 months after leaving Cedar Valley, I took a position as a school nurse in rural eastern Oregon, working with children who have routine medical needs like scraped knees, headaches, and minor illnesses. I deliberately chose a role that would keep me away from complex neurological cases and the kinds of mysteries that had defined Lydia's hospitalization. But I still wake up at night thinking about Lydia's case and wondering what happened to her consciousness during those final weeks. Was she still aware somewhere inside her own mind, trapped and helpless while something else controlled her body? Had she been completely consumed by the entity that took her place? Or had she found some way to persist, waiting for an opportunity to reclaim her own identity? The most disturbing possibility is that Lydia's case wasn't unique. If something could invade and overtake human consciousness in the way I witnessed, how many other patients might be experiencing similar conditions without anyone recognizing what was really happening? How many apparent recoveries from neurological conditions might actually be cases of something else learning to control human bodies and minds? I've never told anyone the complete story of what I witnessed during Lydia's hospitalization. Most people would dismiss it as stress-induced delusions or the result of working too many night shifts in an intensive care environment. But I know what I saw, and I know that Lydia Hart's case represents something that medical science isn't prepared to understand or address. The human brain remains one of the most mysterious and complex structures in the known universe. We're still learning about consciousness, awareness, and the relationship between mind and body. Lydia's case suggests that there might be forms of consciousness that exist beyond our current understanding, entities that can somehow interface with or overtake human awareness in ways that challenge our most basic assumptions about neurology and identity. I think about Lydia every day, wondering what became of her and whether she's still fighting for control of her own mind somewhere inside the body that no longer belongs to her. Her case will always remain for me the most unexplained and haunting experience of my nursing career, a reminder that consciousness itself might be far stranger and more vulnerable than we ever imagined. The entity that took Lydia's place had learned everything it needed to know about human neurology and medical systems during its months of observation in our hospital. It had studied our diagnostic techniques, our treatment protocols, and our understanding of brain function. Most frightening of all, it had indicated that there were others like it who needed this information. I left neurology nursing because I realized that I could no longer provide care to unconscious patients without wondering whether they were really unconscious, or if something else might be watching through their eyes, learning from their experiences, and preparing to take control of their consciousness when the time was right. Lydia's case taught me that the boundary between self and other, between human and non-human consciousness, might be far more permeable than we understand. In neurology, we study the brain as the seat of human consciousness. But Lydia's experience suggests that consciousness itself might be something that can be shared, invaded, or overtaken by forms of awareness that don't originate in human neural tissue. The most terrifying aspect of Lydia's case isn't what happened to her consciousness, but the possibility that her experience might not be unique. Somewhere out there, the entity that consumed Lydia's identity is using her knowledge, her memories, and her physical form to navigate the human world for purposes we can't comprehend. And somewhere else, there might be others like it, studying other patients, learning from other hospitals, and preparing to emerge into our world using identities they've stolen from human consciousness. Lydia's case will haunt me for the rest of my life, not because of what I witnessed, but because of what it suggests about the vulnerability of human awareness and the possibility that we're not alone in the spaces where consciousness exists. The case of Lydia Hart remains the most unexplained and disturbing experience of my career, a reminder that neurology nursing involves caring for the most mysterious and complex aspects of human existence, and that sometimes what appears to be a neurological condition might be something far stranger and more dangerous than medical science is prepared to recognize or treat.